So ice is very, very important because basically very important to understand what the patient thoughts about their condition are. Okay, so you can ask the patient, is there anything that you feel could be the cause of your symptoms? Because basically you should address the patient's ideas, concerns, and expectations. For example, if a patient comes to you with headaches, right? And if you don't understand why they are coming to you today or what their concerns are, you might end up by not meeting the patient in the middle. Okay. So, for example, if a patient comes to you with headaches, then you keep asking them questions about stress, about causes of headaches, differential diagnosis, and then you don't really understand why the patient is coming. Okay. So you say, okay, so I recommend on prescribing like simple painkillers. If you do think, for example, if a patient got some sort of tension type of headaches, okay, then the patient might not agree with you because basically they do think they have got something sinister, such as cancer, which you didn't touch base about. Very important. However, the patient might have not got any cancer at all, but again, they're concerned about it. So you should address that. So you can say, right, I can understand where you're coming from. However, based on your symptoms, based on what you told me today, I don't think it's cancer because you haven't got like severe headache, you haven't got any nausea, vomiting, you haven't lost any weight, you haven't got any problems with your vision. Okay, so you can explain to the patient why you do things they haven't got, what they do things they have. Okay, so idea is very important. Concerns, like we said, so sometimes can there be like a sort of overlap between ideas and concerns? So some patients actually might haven't got any idea about what they have got, but again, they most of the cases they have got a concern. So for example, you can ask them any idea about what have you got or what problem you have got. So they say, oh no, doctor, I've got no idea. You please tell me. You're the doctor. Okay. But concern, what are you concerned? So there must be a concern, and that's why they are here today. Okay, in most of the cases. Is there anything that you're worried about? This is how to ask about concerns, anything that you're actually concerned about, and expectations. At the end of the consultation, you can do that, or you still can do that during history taking. I prefer to do that during history taking. And the reason behind that is actually to try to understand what the patient is hoping for. So how to ask about that? So are you hoping for anything in particular from our today's consultation? Okay, so if a patient concerned about like a brain cancer, so what you're gonna do if you're gonna, for example, like request a CT head scan, okay, the patient is expecting you to do that. Okay. However, if you don't think the patient has got cancer or anything that needs to be investigated at the moment, so you should explain to the patient why you don't think it's appropriate here. So ideas, eyes, concerns, expectation, please try to include them in every single station, or at least to ask about the concern, because in most of the stems, they ask you to address the patient concerns. Okay, so very important. Effect of symptoms, psychosocial aspect, very important again. How has this affected you? Did it affect your sleeping? Did it affect your daily activities? Did it affect your work, your relationships? Okay, because you know, you need to understand how this impacted the patient life. And by that, you can help the patient actually. So if they've got mood issues, if they've got depression issues, and you didn't ask about sleeping. Sleeping can be one of the reasons why the patient has actually got low mood, okay? If you're deprived of sleeping, you can be like very sensitive, you can be in a low mood. So still you can address that. It's very important. to try to help the patient as much as you can. What does your partner think about this? If your partner is supportive, what do you do in your free time? Has it affected your hobbies? Does it stop you from doing that? Okay. You can ask these questions, and at the same time, you still don't have to ask these questions. So the main one here is, how has this affected you? Okay, has it affected your sleeping, daily activities? Has it affected your work? Has it affected your relationship? Okay, that's the main thing. That's social life. And psychological aspect. Does this cause you any anxiety? How is your mood on a scale from 1 to 10, where 1 being the lowest mood and 10 being the highest mood? Okay, again, use these questions in place. Please, doctors, you don't have to use these questions in every single station. However, if you do think the patient, their life have been affected by the symptoms, in most of the cases that can happen specifically with chronic situations like chronic headaches, chronic pains, very important to ask these questions. This is how you're going to help the patient. This is a holistic approach. This is a patient-centered approach. You're not only here to ask the patient questions medically, but at the same time, you still need to address any psychological aspect behind the patient's symptoms, okay? Very important, psychosocial aspect. Summarize. So let me go through everything you have told me so far to make sure I have understood correctly. So then summarize history. Then is there anything else you would like to add on? Is there anything I have missed at all? So that's to summarize during history taking. So please, doctors, bear in your mind, please, as much as you can, never exceed 6 minutes taking history. The exam is only 8 minutes. Very important to bear that in your minds. Some, I'm just going to say not some, but like most of doctors ask me, oh, Dr. Khaled, do you think within 6 minutes we're going to do all of that? Yes, you can. It's not impossible at all. And the only way you can do that is actually by practicing. So keep practice and practice and practice. You will nail it, definitely. Okay, so please try to do that every single station, and then you'll find your own way in order to do like time management in time, you know, like to do history taking 6 minutes, in addition to try to speak about your management plan perfectly in another 2 minutes. Okay, perfect. Here it comes examination. So examination, I divide it into observations, specific examination, and bedside tests. Okay, so observation signs. I'd like to check your vital signs, Mr. Joan. I mean by the blood pressure, pulse, oxygen, respiratory rate, and temperature. Okay. Specific examination, which actually relates to the symptoms the patient have got. I'd like to examine your chest, for example, if they've got chest pain. Is that okay with you? Okay, always gain consent from patients before examining them, which is very important. Just giving you some examples, try to make it as more layman language as you can, as much as you can, whenever you're speaking to your patient. So I'd like to examine your chest in order to listen to your heart and lungs. Is that be okay? All right. Abdominal examination, I'd like to have a little look and feel of your tummy. ENT examination, I'd like to have a little look into your ears, examine your nose, and examine your throat. Okay. Eye examination, I'd like to have a little look into your eyes. I'd like to have a look into the back of your eyes. Neurological examination, I'd like to examine your nerves. Leg examination, for example, I'd like to have a little feel of your legs, just to check for any abnormalities, just to check for the circulation in your legs. Perirectal examination, and can I examine, would you mind if I examine your back passage and the reason behind that? So always, whenever you're doing a sensitive examination, so first of all, you need, like I said, with any single examination, you need to gain consent. Second thing, you need to explain why you're doing this examination for. Okay, specifically sensitive examination, you should explain. So if, for example, if a patient has got urinary symptoms, like a male patient who is 60 years old, he came to you with nocturia or frequency to urinate. You excluded like a urine infection doing a urine dipstick, but you're still suspecting this patient has got a problem with their prostate gland, like a prostate enlargement or even prostate cancer. So the only way you can do that is doing a perirectal examination. You need to justify why you're doing this, because if you say, Mr. John, can I please examine your back passage? So the patient might think, why this doctor does need to examine my back passage? However, I only have got like urine symptoms. So you need to justify. So the only way I can examine your prostate gland is by doing a back passage examination. Is that all right? And again, with any sensitive examination, please, doctors, ask for a chaperone, even if it's the same sex. So if you're a male doctor, you're gonna examine prostate gland, please offer a chaperone. Okay? Never forget about this. Head-to-toe examination, right? So that's a kind of a general examination as well, in addition to specific examination. Bedside tests, again, we need to do that only if it's appropriate, only if it's relevant. Urine dipstick, urine pregnancy test, ECG, capillary glucose levels, which basically, so for example, if a patient comes to you with chest pain, so irrelevant here to be their urine, because you're not gonna get any finding from doing this, okay? So keep in your mind how relevant questions are. Like I said, whenever you're never asking or offering any examination, blood test or whatever, so please make sure that you're asking and you're requesting the relevant things. Provisional diagnosis. From what you've told me so far, and after examining you, then unfortunately, I suspect that you may have what we call, and then say the provisional diagnosis, what's in your mind. Here, when it comes to unfortunately, do you think, doctors, is it always appropriate with every single provisional diagnosis? From my point of view, I don't think it's always appropriate to say unfortunately, because every single diagnosis, you don't have to be sorry about. You don't have, unless you're actually breaking bad news. So that's another thing to say, oh, unfortunately, I do suspect you have got cancer, for example. Okay, but you don't have to say unfortunately with every single diagnosis. Is it important to say the diagnosis or provisional diagnosis? Yes, it is. Very important. You're going to be marked down if you're not telling the patient what your thoughts are or your role player, even if it's wrong. Okay, at least you have expressed what your thoughts are about the diagnosis. Please try to do that. Otherwise, you might be marked against that. Okay, so very important to speak about what your thoughts are if it's a station that needs a diagnosis. Explain diagnosis, investigation, okay, in a layman language, like I said, right? So don't say, we're going to do an FBC. So the patient doesn't understand what full blood count is, right? Like a simple blood test to check for any sort of anemia or infection, okay? Like I said, again, please, doctors, do that in a layman language, a language that the patient can understand, right? So diagnosis is important. Management plan. So I always would like to start my management plan by doing, again, some sort of investigation if I didn't do that earlier, okay? Or the other sort of thing is additional investigation, okay? Always try to explain to the patient why you're doing these tests for. Why are you doing these tests for, okay? So full blood count, why you're doing a full blood count. What's the full blood count is? Use and ease, liver functions, blood sugar levels, ESR, CRP, which are inflammatory markers, very important. Treatment, if you do think a patient has got conditions that can be treated, so you still need to share that with your patient. Always put in your mind, doctors, please, in the management plan, as much as you can, make it an interactive management plan. And by that I mean, include the patient. I don't want it to be a one-way conversation. I need it to be a two-way conversation between yourself and patient. But again, do not overly do that. I don't want you to waste your time in management plan. It's almost only 2 minutes to speak about your management plan. So, for example, if you spoken about treatment, so if a patient has got, like, you do things, they have got chest infection, you're going to start them on antibiotics like amoxicillin if they're not allergic to penicillin. Then after that, how does it sound to you? All right, so the options might be a treatment such as an antibiotic, which treats chest infection. How does it sound to you? How do you find that? Okay, are we on the same page, right? But you don't have to do that after every single step. You can do that after 3 steps or something like that. Okay, like if you said, spoken about routine investigations, treatment, decision, and the decision here is either to admit the patient to the hospital in case of emergency or in case of the patient needs to get admitted for any reason. If you're going to discharge the patient, if you do things that you have completed the course of management or course of treatment for this patient, or referral, if you're going to refer a patient into a specialist. So these are the 3 main things that you need to consider while taking a decision, either to admit the patient, discharge the patient, or to refer the patient into a specialist. Safety netting, again, we've spoken about red flags early on. So safety netting, never end the station without safety netting, doctor. Safety netting saves the patient and saves you as a doctor, saves your GMC number, okay? Because by safety netting, you are doing what we call a patient-centered approach. Basically, you're not only telling the patient or asking the patient to go home and that's it. No, you're telling the patient, I am going to send you home today, for example, and please at any point of time, if you get any red flags, okay, red flags, if a patient comes to you with headaches, so you always give them this advice about if they have got any arm weakness, any leg weakness, any blurring of vision, any early morning sickness, for example, right? So at that time, please seek urgent medical advice. Either to speak to 999 if in case of a life-threatening situation, or 111. So we're going to speak about that later on. But safety netting, and the way I do it is actually to do it as early as possible in the management plan. Follow-up. If you do think the patient needs to be followed up, so very important to offer that to the patient. Every single patient who needs to be followed up, it depends on whether you do things that they need to be reviewed a couple of weeks, they need to be reviewed in 48 hours, or like in 4 weeks' time. For example, I'm giving you an example of a patient who is actually like a 2 years old, came in with his mom, who's actually worried about him. And you do think he's got like a viral infection, like bronchiolitis, something like that. But his traffic light system, we're going to speak about that in detail later on. But you do think that his observation signs are fine or borderline. But again, the patient doesn't still need to be admitted to the hospital. However, you safety net mom or you safety net parents, if symptoms get any worse, if he's unable to breathe very properly, if he's not eating or drinking fine, if he's not weeing as he normally does, please at that time seek urgent medical advice. Okay? And please, the way to do that within the next 48 hours. I'm going to give him a call in 48 hours if you're in GP, for example, to make sure he's all right. Okay? Another patient comes to you with skin rash and you do think they have got eczema. Okay? So eczema, I do suspect management of eczema and the patient to get better on treatment of eczema in like 3-4 weeks' time. It doesn't make sense to say, can I review you in a few days' time? Because that wouldn't really solve the issue. I mean, this issue wouldn't be solved in 3 days' time. So it can take them up to weeks until they get improvement. Okay? Leaflets, that's one of the things that actually really beloved in UK. So give leaflets to your patient. And believe me, doctors, every single situation, every single diagnosis, you still can give leaflets to the patient to read about. Okay, so leaflets, because for example, if the patient goes home today and then they forget about what you've told them, like most of patients can't forget about what you've told them today, right? So the only way they can remember that in an efficient, professional way is to give them leaflets so that when they go home, they read about their situation in a better way, or even they can recall what information you've given to them today. Again, summarize. Summarize is very important because basically, if you speak a lot and patient might get lost in between. So summarize what you've said if you get any time, and expectation. What do you think about what we've discussed today? So you're sharing that with a patient. You're trying to see whether the patient understood what you've told them today. And again, it's a very good way to gain some marks of, I was going to say, building rapport with your patient. So that's very, very important. Try to do that. Try to do that as much as you can while it's your practice. So again, doctors, the only way you can do that is by practicing. My video, I'm gonna record my video. I've already recorded it. I'll be sharing it, but please let me know so that I can add you into my Google Documents so that you can have a little look into it if you like at some point. And again, like I said early on, we're going to start the Plab 2 course very soon. So please subscribe, doctors. You'll gain very good benefit of joining our course. We're still going to do free sessions anyway as well. It was very lovely to see you today. Thanks so much for participating. Thanks so much for attending, and have a lovely evening.